I've been given so much by the healthcare ecosystem over time with the relationships, the camaraderie, the opportunity to mentor folks. I want to give back. What value can the folks that we've already done our service, what can we do to help the folks that are leading the charge now? And how can we contribute to their success? The technology's there, but what are we going to do with it? You still need a human perspective and an emotional intelligence for the organization. Make sure your staff are keeping up with what's going on. Make sure that they have the tools and equipment to do their job, and listen to them. Not hear them, but listen to them.
Hey, everyone, and welcome to Smarter Sourcing Healthcare, the podcast where we talk to supply chain leaders in healthcare that are doing innovative things and working on the problems we face today. If you're in the healthcare supply chain, you know that we have no shortage of challenges. There's labor shortages, there's technology challenges in the world, and we're just trying to figure out together. The only way forward is together. How to address those challenges. And today, we're joined by a great supply chain leader, Charlie Miceli. Charlie is retired recently as the Chief Supply Chain Officer at the University of Vermont Healthcare Network. Charlie is a Bellwether League member, 2023. He is a supply chain, healthcare supply chain lifer, an industry icon, and a Renaissance man. Charlie, welcome to the podcast.
Yeah, thanks. You make me blush, Eric. So
You've been a tremendous addition and contributor to the industry over a lot of years. And maybe I just wanted to kick that off. I mentioned the fact that you're a Renaissance person, rock band leader, chief supply chain officer, interim CFO, CEO of a health system, also chief technology officer of a health system. You're also on the board of the patient safety movement. Which one of these do you identify with the most? Or do you have others that are in your repertoire of things that Charlie Miceli does?
yeah, I identify now as a retired family man. So, but I guess my focus is I've been given so much by the healthcare ecosystem over time with the relationships, the camaraderie, the opportunity to mentor folks, and I want to give back. And I've tried to do that throughout my career. Continue to do so. And with the way that the industry is going now, what value can the folks that we've already done our service, what can we do to help the folks that are leading the charge now? And how can we contribute uh, to their success and ultimately to better and safer patient care? Because that's what we're in it for.
Yeah, no, that's true. And you've had anchor relationships and participated in lots of different industry groups that have supported that in the past. And maybe, because you wore some different hats at the University of Vermont over 15 years, the reporting relationship with supply chain and how it integrates into the fabric of care and management and leadership. Do you have a perspective on where supply chain should report to and why? How and where does it work best, integrated into the organization?
Yeah, I guess the not textbook answer, but the human answer is who's ever the best boss and the best leader. Uh, I've been fortunate enough to, over the last 17 years, to report into the CFO. And three different CFOs, all stand up folks, great leaders, mentors, but that's been my preference. But prior to that, I did serve under chief operating officers, and that was good too. But I'd say the CFO, because you can get the finance perspective closer and learn more about the infrastructure of, because you have to know operations anyway. So, and if you can understand the numbers, the funding, the pressures that are there for the CFOs and their teams, I think is That's the preference. That's where I'd want to be.
Yeah. And the only maybe one question on that, because I've seen a few of these roles that were chief supply chain officers that now organizations are taking to chief procurement officer. It seems to be kind of shifting back to more of a sourcing focus, which only seems to be a part of it for me. Did you ever have any challenges with that, or it was just pure sourcing, CFOs, price at the pump kind of people versus kind of the more integrated view of supply chain related to clinical and others?
Back when I started, it was 3 bids and a cloud of dust. So, we're and that's how I was brought up. But, that works really good when everything's nice. But when there's challenges and, we had challenges all the way back in the late '80s with supply continuity of supply, availability of products, the relationship with the supplier community, I got rid of the word vendor in probably 1988, and it was supplier. And really, when you look at the healthcare industry, there is an aspect of altruism with the companies that participate in there because it's some way, shape, and form or some time somebody had an idea to help out a patient or help out a process that supported a patient in that industry. And that took me a little bit to learn when I first started because I came out of the packaging industry before I started in healthcare and back in the day. And just a different world. But they're patient at the end of the whatever you do on the healthcare side, whether you're in supply or in accounting or, nursing or whatever professional group that's there, it's very important it's a relationship. And I think, and then there was the move from just the 3 bids in a cloud of dust to who can have the best contract. And, you had terms and conditions that were pretty much weighted back in the late '80s were more weighted toward the suppliers, um, and it was just business terms that you just signed off on and, hopefully nothing went wrong.
Your brand has been as a collaborator, both with technology partners and with suppliers. I'm glad to hear you use the word supplier versus vendor. What benefits did that provide you? Maybe in the more recent past of things that created new and unique relationships that benefited the University of Vermont Health Network.
Yeah. When we sat down with a supplier, a strategic supplier, and a strategic supplier could be somebody you spend multi-millions with or multi tens of thousands because they support and they line up with your requirements to take care of the patients and run your operations. I guess the big thing there is trust. How do you build the trust? And that becomes a salient point when something goes wrong. So no entity, no outfit is perfect. So when the yogurt hits the fan, how does the customer and how does the supplier show up to balance that out and solve number one, and then make sure it doesn't happen again? And when we sit with our suppliers, whether it's a distributor or a tech manufacturer or an IT company, that relationship is what gets you through the dark times or get you through the problem. And you know, threats. That was the old way of doing it. I'm going to call the president, and you made threats, and it was an antagonistic relationship. Didn't work. I mean, it works once, and then something's gonna happen again, you're gonna need somebody. What I found out of the whole thing, Eric, is never burn a bridge because the way people move throughout the healthcare ecosystem, whether you're on the supplier side or on the provider side or even in the middle as a consultant, it's a small world.
Yeah, no. In the next 3 to 5 years, where do you see, kind of this going, in AI and technology platforms, and what problems do you anticipate being solved through that?
I'm seeing it's the new ERP. So we went from these transactional accounting systems, inputs, outputs, have a detailed trial balance at the end of the day, which we used to have back in the '80s, where now you're doing you're projecting what's going to happen down the road with algorithms, sensing systems, data control towers, all the different terminology that's out there. I think we're in that next phase where AI, it's a starting point. How can we make that work for us? It took us a long time, several years, to get the ERP systems tuned up so they would inform us. I think we're at that same stage now with AI where the technology's there, but what are we going to do with it? And it's not just a headcount mover, if you will. It's not a headcount reducer necessarily. It could be because the waste process it takes mood. It can help us take muda out of the system that we've already tried to get out, and maybe it's the next level, cracking that next barrier. But you still need a human perspective and an emotional intelligence for the organization that has to drive this thing. And I think it's some I can't remember if it was Ruben Pillay or one of the, futurists, but it's almost like a minotaur where you got the power of the horse, but then you still need a brain and a somebody to and an emotion to care for, because again, this is patient care at the end of the day that we're supporting in our group. So I think, it's trust but verify from my perspective on how AI applications work, or any of the data systems where, the LLMs, or even something that even with the agentic components, you still need somebody driving it and working it. So I think we're in that inflection point now, and let's see what happens.
Yeah, there's been some great developments, right? It's the early innings of this, as I always say, but some great opportunities. And you mentioned the LLMs, large language models, and you had mentioned to me that there might be the possibility to leverage AI for succession planning and mentoring. Can you elaborate on that? What does that mean to you? How do you see that working?
With AI is scary because, the first thing you look at it says, "Oh, this is gonna take my job." It can look at an LLM in a contract database, and that's been happening for at least 10 years on contracting. Well, that's just the terms and conditions. What's the life cycle of the contract? How do you make that support your organization? An algorithm's not gonna do that. It's gonna help you measure, but that human factor of the relationship is still important, and it should the AI component, or I'm gonna just use technology. The technology component should give you more time to do critical thinking to help support your organization. And, you know, I was fortunate in my chain of command. I had people that were way smarter than me working in my group. And so what I could give to them was just experience and exposure to technology. And I think that's what leaders should do now, is make sure your staff are keeping up with what's going on. At a minimum, just be aware of what's happening.
Yeah, no, that's great. And you also told me that you had a Venn diagram in your head of how sourcing and procurement from other industries could be aligned to healthcare sourcing and procurement with some tangible benefits that came from technology. Can you share your thoughts around that?
Yeah, sure. So I started out in procurement in industry, and not non-healthcare, where it was manufacturer planning. And I still remember when I first became a director of procurement, there was a shortage on, I can't remember, I think it was, latex exam gloves. So I went over to the purchasing buyers and I said, "What's the production rate on the gloves? I mean, how many gloves do these plants make on a daily basis?" They go, "We don't know." I go, "What do you mean you don't know?" "Well, we get it from the distributor." I go, "Well, what's their inventory, fill ratio?" "Well, we don't know. We just know that we negotiated a cost and they deliver the product." And I said, "Well, we got to start learning, what our production rates are. What's the continuity of supply? What are all the different components in there, even getting down to raw materials?" And it's progressed now that, we look for Where are the raw material ingredients? The APIs for pharmacy, for, uh, what are the impacts of what we've learned through with, all the risk management modules and the risk management systems. The pandemic was kind of the wake-up call for us to really understand more, because most of our procurement has been indirect. If you look at your supply, you're going through a distribution channel, and that Venn diagram to bring in those practices that, strategic supplier management, SSM, has always been on the non-healthcare side in big industry. And that's accreted into the healthcare ecosystem now, which is great. I think the more line up, and ARM's done a good job developing and, building the organization to support a broadening effect of what supply chain is in procurement into the healthcare side, taking from the what I call the real world. I never really participated in the healthcare supply chain organizations. I belong to procurement leaders, to ISM, it used to be called the National Association of Purchasing Managers. That's where I got all my lifetime certification, et cetera, working through those organizations. And that's why I said the Venn diagram, but they are getting closer, which is great. And there's been more healthcare, I think, with the new leaders that are out there, and the folks that are, at the tail end, they've realized that, and uh, they've embraced that.
Yeah. So I'm going to shift gears a little bit, Charlie, and talk about another passion for you, which is the patient safety movement. It's unique for you in an area I know that you've had high passion of. What for our audience? What is the patient safety movement? How did you get involved, and how can healthcare supply chain, best support it and lean into to improving patient safety?
Yeah, the Patient Safety Movement Foundation was started by Joe Chiani, who was the founder and CEO of Massimo. And in 2013, there was the first Patient Safety Technology Summit that was run out in California. Major corporations, healthcare corporations were there. President Clinton and other politicians came in to support, as well as patients and families of patients that were harmed by medical error. And medical error could be omission of care, could be a drug error, or just a procedural error. And over 250,000 patients are mortally injured annually. And this was an attempt, and has been an ongoing mission, to mitigate patient harm. Our initial was 0 deaths by 2020. Obviously, we didn't hit that number, but it's really do no harm, and tie into Dr. Lucian Leap's imprimatur that was put out earlier. I was involved as a musician first, but then as I was participating, I was also serving. I had biomed responsibility, as well as IT and leadership, and saw, boy, we should get more involved in this. And from a supply chain perspective, we had the relationships with the suppliers as well as with the EHR companies, and the technology and the data that was used in technology. How do we safely collect that data? And then how can we share that data to make each of these systems run safely, and contribute to improve care and mitigate errors? And the first thing that we did from a supply chain perspective is we shared our architecture steering committee checkoff document whenever you brought in either a new application or wanted to share data. Do we meet all the regulatory compliance rules that were there from that side? But then also, can the systems talk to each other? Can, Epic talk with McKesson PACS? Can GE talk with Epic? How do we set up this whole component of interoperability, which we have to have that on the supply chain side when we're sending information from our ERP systems to make sure we have continuity of supply. Well, can we have the same thing with continuity of patient care data and share that. And that's evolved over time. And also from a government perspective, our government's done a great job, making that a requirement that you have clean data, that the data can be shared. And ultimately, from a supply chain perspective, can we leverage our relationships with the supplier community to make the data pledge, to share the data, to take care of our patients in a better way?
Yeah. And there's a great data component of that. There's also the value of service, right? Having the clinicians have the time to provide the care in a consistent manner. I don't know, did you ever dig into, kind of that value of service and product continuity? Does that play a role there or not?
Yeah, one of the cool things that I experienced over my tenure is when I worked in IT. And again, like I said, I always had a lot of people that were 10 times smarter than me. I just helped them do what they wanted to do. Is we were able to get an interface where a radiologist could work in the PAC system, but then also have Epic show up at the same time. You have the EHR. This is before Radiant, which is the Epic radiology system. This was back before that when that was first being developed. We were able to have the physicians to have that, the radiologists to have that right in front of them. And that was a keynote presentation at the RSNA because they hadn't been done before with a non-Epic, product, and we were able to the tech folks were able to work that out, and from a physician satisfaction perspective, it was a grand slam. And, it was that was just so meaningful to have that. And actually, the first time we did it was how did we have and I saw this in an old email, an archived email, when we had the biomedical device integration with our monitoring system with Epic. So a nurse didn't have to write in the vital signs or type in the vital signs. They just pushed a button and the monitor would send the data into Epic. I mean, that was, you know, and my wife's a nurse, that took a load off, and let them do more things to support the patient or even take care of themselves because it's such a stressful job. So, yeah, I mean, that was pretty cool.
Are there ways that you would challenge the current healthcare supply chain leaders to engage more with patient safety, both at the, I don't know, procedural hospital level as well as all the way through kind of population health and the way that that's supply chain can impact that?
Back in the day, we leveraged the whole cybersecurity component because that's patient safety. And if supply chain isn't involved in making sure that we meet all the requirements of cybersecurity, we're not doing our job. That's like we're not monitoring continuity of supply. We have to monitor continuity of cybersecurity too, because it's our job to manage that supplier relationship and the suppliers beyond that. In fact, back in I want to say 2016, I was fortunate enough to work with our president at the time, Dr. Dave Mayer, who ran the MedStar Safety Institute and started it. Dr. Mayer and I presented at Gartner and talked about cybersecurity. And right then, that's when the WannaCry virus had hit the NHS. And it showed where if you didn't have everything ticked and tied with your suppliers, there was a risk that was there. So that's critical. And we have to continue to do that. That risk is there. You see data breaches on Resolute. You see look at the Change Healthcare issue that occurred. Supply chain, we had to get involved in that to work with the suppliers to make sure that they were, were they okay or were they at risk?
Yeah. Well, thank you for all your support of patient safety. That's been a really cool chapter of your life, and appreciate all the support there. Maybe just a couple last questions. One about the untouchable areas of supply chain, historically sacred areas. How do you see that being addressed in the future? What would you say to the industry and our audience about going after those untouchable areas of supply chain?
Not necessarily untouchable. They were not looked at. So maybe not it was opaque. There was a spend there, but ERP systems and our financial systems, there's more transparency there, and some of the ancillary analysis systems that are out there, you see spend that we never really touched, or never really, our end users worked with the best that they could with their supplier relationships that they had, but we had no comparative opportunity, if you will, to see where we stood. But over the last 3 to 4 years, there has been pursuit of the non-clinical spend areas. And I don't necessarily, we were brought up, sacred cows make the best hamburger, but but you know, it just wasn't something that supply chain got involved with, whether it was in, HR spend, it was in, contingent labor, facilities. But now if watching LinkedIn and looking at all the things that the group purchasing organizations are doing, special organizations like Logic Source and other components, folks that are out there, they're bringing that real world aspect into the healthcare system to really take a look at how we're managing that spend. And in some cases, it's managed very well. In other cases, it's like it's never been looked at because it's like, yeah, it's 100,000 bucks a year. Well, that 100,000 is very important when you're not making your numbers. And if it's 1/10 of a million, so you got to put eyes on it. And I think with some of the tools, the AI tools, the analysis tools that are out there now, if that gives us time to go look at the spend in these other non-clinical areas, or spend where supply chain really didn't get involved on, we get involved now. And that's why I like the reporting structure into the CFO, because you get to learn where these other spend structures are. And but you become tight with the GL and see where that spend is, whether it's in contingent labor. And we're not the experts in that, but we facilitate and we support and look for the best processes to work that spend so it's fair. We're not, and fairness is there. That companies have to make money to survive, and we have to have a margin so we can take care of patients. And I think it's very important for us to continue and don't close our eyes to a spend that is there. There's also, you have to look at local geography, local availability, where you stand, and make sure that you can have continuity. The lowest cost always isn't the best cost. And you have to make sure what's the best fit for your organization. And again, what's fair and what gives us continuity of service is critical.
Yeah, no, well, just super well stated, right? That area of spend is 40% of supply chain and tends not to have great governance over it and all the variability that you talk to around service.
But that's where that Venn diagram comes in, is that there's the real world industry saw that where they can help. And, it takes time, it's governance, it's culture, and some organizations can go faster. And, but the whole concept is totally valid. And if you don't look at it and don't try it, you're not doing your job. So that's all I have to say about that. So.
No, I appreciate it. Well, we're coming to the end of our time. Really appreciate all that you've shared. Are there any parting thoughts that you'd have if you were starting up in a healthcare supply chain leadership role at a provider today? Is there anything you'd do different or advice that you'd give to our audience?
For the leaders that are there today, embrace your staff, make sure that they have the tools and equipment to do their job, and listen to them. Not hear them, but listen to them. And make sure that the decisions that are made are analyzed with ground truth and accurate data. Because if you don't have that, then you're just, shooting at it, and maybe you're doing ready, fire, aim versus ready, aim, fire. And sometimes you have to do that. But there is an emotional component when you're tying into this. But the other thing is that make sure that there's flexibility with what your folks are doing and what they can do. Don't pigeonhole them into one slot, because sooner or later technology is going to take that slot. But if they can build their skill sets to do other things and help the organization, that's when you're a strong leader. That's my perspective.
Amazing. And with that, Charlie, thank you for being here. And to our audience, thank you for your continued participation and feedback on the podcast that we've been doing. On behalf of Smarter Sourcing Healthcare, I'm your host, Eric O'Daffer, and I hope you all have a great day.
Thank you, Eric.